Hi, we're here talking about a return to healing, which is our book and our website and our podcast. And I'm here with Alan early in Sunday morning, talking about medical care and some of the things we've seen recently and some policy things that we thought you should know about. And we wanted to talk a little about somewhat cardiac care, but also specialty care in general versus primary care. Because we're two primary care physicians, and we sometimes struggle with this. And it's been not only a problem in our own practices and among our own patients, but also nationally. It's a huge problem because the amount of money we're spending doing things that actually are either inert or hurt people is far higher than the amount of money we're spending to help people, which is truly something we have to change. And I saw someone this week, Alan, that he's a really pleasant guy in his mid 80s. He bicycles 10 miles a day. He travels. He has a very active life, and decided his wife told him that he should get a routine cardiac screening. And he had some fluid on his legs. He went for a stress test. Mind you, this is a guy without symptoms. They found a way to give him a stress test, an echocardiogram, and carotid Dopplers. Where I live, this is the norm. You go to a cardiologist's office, you're always getting an EKG, even if you have no symptoms, but you might get these three tests, which are incredibly expensive, but also could lead to problems. So they felt like he had some swelling, and they got a chest X-ray, and they thought he had a little congestive heart failure. Mind you, he had no symptoms. Then they went through this echocardiogram, which was normal, but they thought he had some amyloid on it. Amyloid is a protein that could build up in the heart, the brain, other places. We don't even know what it means. Mind you, we don't know what amyloid is. We know, for instance, in the brain, people with dementia have more amyloid, but a new drug that came out at 50,000 a year, which reduces the amyloid, doesn't help your memory but causes brain bleed. So it could be the amyloid's holding stuff together. We don't know, but he got on the train. He had an amyloid scan of his heart, then was put on four new medicines, one of which is costs over $100,000 a year, is to reduce the amyloid. When he came in to see me, he said he could no longer bicycle. He felt miserable. He was tired all the time, and he assumed it was from his heart because they had diagnosed this horrible condition. And I explained to him that no, these new drugs they had just put him on were probably wiping him out. He's on a diuretic. He's on two blood pressure medicines. He now had low blood pressure. He's on this amyloid thing that has not had good follow-up despite early FDA approval. We have no idea if it works. And this is the problem I ran into. People come in thinking they're getting this care, thinking that they're just being safe, and they end up diagnosed with a condition that is phantom, and the treatment of it makes them sick at a huge expense. So I see this all the time. This is just this week, but I see this every day. I mean, Alan, you must too.
Yeah, so we could go through that with multiple diseases besides cardiac, people for going for unnecessary endoscopies at the gastroenterologist and patients that go to a gastroenterologist, an endocrinologist, excuse me, for endocrine things. They come back with 17 pages worth of labs, and half of them I've never even ordered in my life that don't make a difference in people's lives and cost someone $3,000. But we see the negative effects in primary care of all of this specialty care because, we know that if you test, you will find stuff, and most of what you find is meaningless. Or we don't know if it's meaningful or not because it hasn't been studied. So the overtesting leads to overdiagnosis, which leads to overtreatment, which leads to harms. Okay. And many of these cardiac patients end up with interventional procedures. The bills end up being hundreds of thousands of dollars. And folks think that, well, more care is better care. Like, the more tests I get, the healthier I'm going to be, the more they're going to find. You're going to cure something early. But we really don't find things in that way. There's very few things that, we find through prevention. So, Andy, taking your case of the heart, I recently had a patient in the palliative care, and I treat end of life care and pain. And the patient came in after, going for their routine stress test that Andy talked about. And in my world, it's interesting because I practice in two worlds. I practice in probably the poorest population in our country, and in a middle class. We have two practices that work there. And honestly, the people in the poorer areas get better care because they get the appropriate care, and they don't push the doctors and the specialists to do things that they don't need. And when you push a cardiologist to do a cardiac cath, who's going to make $20,000 on that procedure, like, he's not exactly angry about it. So cardiac caths lead to complications. So this patient that we were talking about went for a cardiac cath. They put a catheter in through your groin or your arm. In this case, it was through their groin. And they ended up getting a blood clot in the leg. And this was a cardiac cath that they didn't need, that came up with an equivocal stress test on their annual stress test. And the clot literally killed their leg. It took the blood flow away from their leg because they went into the vascular system there. And when they went in to try and fix it, the patient had a stroke on the opposite side of the body. So now the patient has no right leg, can't use their left leg, and they went in for a normal stress test. So there is harms, and this is not an unusual story. We see the harms from overdiagnosing things all the time, especially overtreating. Okay. So, we've talked about prevention in the past, and we know about some of the preventive tests don't have a lot of data, and they pick up little things that we don't know is important, and people end up going for more invasive procedures, which could kill you. And people don't realize that. And, the evidence, which unfortunately, as we know, is very little for so much of what we do, or what we do know changes today, is going to be gone tomorrow. And, patients don't care about that. Patients care about what they think they're getting is right. And like I said, if the patients in our inner city practice who love their doctors, who, sometimes follow what you say, sometimes don't, but they do their best, like, they get better care than richer folks who are pushing for unneeded crap.
And there's a lot of evidence to back that up. That there's evidence that the higher the percentage of specialists in a community, the worse the outcome is. More sickness, more death. And in the case of my patient, they create problems. In other words, they create these diagnoses. Now he thinks he has this horrible amyloid in his heart. Well, I have people who are told they have diabetes and stage 3 kidney disease, which are phantom number-induced problems. I'm not saying diabetes is, but this diabetes was, because they've changed the definition to pretty much. Now, the crazy thing is 75% of people over the age of 70 have either diabetes or prediabetes. Now, are they sick? Are they going to get sick? No. They have this phantom condition because of numerical changes. And the problem I run into, Alan, and I don't know if you see that, because I work in a middle class to upper middle class area where they think the more the better. This is kind of the feeling. When they get these phantom diseases diagnosed, they say, "Oh my God, thank God I went to the specialist, because I would have been dead in a month. Now he's got me going to 4 other specialists, and I got my labs, and I'm getting more drugs and more tests, and now I'll be alive." And I watch them get sicker, but they believe that they have just been given a gift of life because of these made up diagnoses. And that's really what specialists have done in my practice, is make people feel super sick and feel like they have to keep going on this train wreck of more drugs, more tests, more visits, and their whole lives become medicalized. And that's the other thing. Anything that this guy I talked about with the bicycling, he's not doing it partially because he feels sick, but also because he's so obsessed with his conditions now that he mentally can't even do it anymore. So it's been a real problem that the more we spend on this stuff, the worse the outcome is. We see this all the time in big studies, but Al and I, we see this in our practice every day.
So, Andy, you brought up a huge point that I didn't think about before we talked, but people who live in cities that have more healthcare get more healthcare and have worse outcomes. So if you look at medical education in this country, for example, most of the doctors are trained in New York, Boston, Chicago, LA, Miami, the bigger cities. If you live in those bigger cities, the cost of your healthcare, whether it's a dermatologist removing a benign skin lesion or end of life care, is astronomically higher with no improved outcomes. And you end up spending more time in the hospital, more time in the ICU, more likely to die in the hospital than if you live in Montana, for example, where the costs are much less, people live longer, and the satisfaction with the care is higher. More is not better. More is worse. So we need to shift from that specialist mentality of test, 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 treat, 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 treat numbers that we don't know have any meaning, to shifting to primary care. We need to change the way the system is reimbursed. So primary care docs like me and Andy are incentivized to go into primary care and stay in primary care. So the best young doctors want to become primary care physicians, because not that they're going to be a millionaire, but they're going to make a good living and they're going to make a difference in people's lives. And specialists who don't have these continuity relationships don't make the difference in lives that primary care doctors do in so many different ways.
For a specialist to continue to, in the real world, a good medical world, there'd be like 80% primary care, 20% specialists. We would use the specialist when we ran into a roadblock, we needed a procedure. We'd make all those decisions. The specialist would then look over and do something and then send the patient back to us to see the patient only if a new problem emerged. But in this world where 80% of doctors are very highly paid specialists and where they get paid to do things to people, they will do everything they can to not hand the patient back to, especially schmucks like us, Alan, who will tell them not to do all this stuff. Who actually have a relationship with them and know them and understand the true determinants of health, which might be stress reduction in their lives or eating better or exercising. We know these people, so we understand what they can, but specialists don't. So they need to invent diagnoses. They need to do these annual tests. And by the way, a stress test is no cheap thing. In my world, when people walk in every year, they get a stress test, an echocardiogram, and a carotid ultrasound, even though they have no symptoms to justify any of those. The doctors alone who do these tests get paid many $1,000s just to read basically what a tech has just already read. But worse than that, they own the equipment and they get these astronomical facility fees, which for those three tests could amount to $30,000 or $50,000 just for that visit. So think about the amount of money we're throwing away in this. But these patients then are brought down the train, like of your patient, Alan, where their outcomes are horrible. They might be thrown on a lot of medicines. And they say, and too many of my patients say, thank God they did that stress test because otherwise I'd be dead now, which is what the specialists want them to think. And it's hard for us in primary care to push back against that. But this is what we do. And I've been somewhat successful, but I imagine the ones who didn't like my approach are long gone from my practice. But they'll find, because most primary care doctors in my world are palsies with the specialists. They have 15-minute visits, and to make that happen, they refer everyone to everyone else because we don't have a viable primary care system that pays you to sit down and take care of people. It basically pays you to churn people out and send them to specialists. And that the whole system benefits from the specialty oriented system. You get everyone's making more money, but the patients and the total cost of care and the burden on our economy and our infrastructure is what's really hurting. So yeah, but
Yeah.
we have to turn this around. We could do it tomorrow just by changing reimbursement. We
Yeah,
can try to do.
I like to make it simple for my patients. So I tell them all the time, I bring it down to antibiotics. It's a classic overuse in medicine. I get someone in my office every single day that has a cold and they want an antibiotic. People don't understand the risks of antibiotics. So therefore, I either spend 10 minutes explaining to the patient why they shouldn't have the antibiotic. And often the next time they'll say, you know what, Dr. Roth didn't give me the antibiotic. I'm going to go to urgent care next time, because urgent care wants to make these people happy. And they'll get the person out in 2 minutes who comes in with a cold and gives them amoxicillin for their cold. So they're thrilled about it. I had a recent example of an adverse outcome from that. So as a classic patient of mine who I would always fight over antibiotics, he went to urgent care for a cold. He was given amoxicillin, and he went back the next week and he wasn't better. And they gave him clindamycin. Clindamycin is a very potent antibiotic, one of the drugs that's highest associated with antibiotic-associated diarrhea. The guy came into my office the following week with a fever profuse massive diarrhea and dehydration, and I had to admit him to the hospital for what's called C. difficile enterocolitis from getting 2 quick antibiotics in 2 weeks. Antibiotics kill people. Everything we do kills people, but people don't realize that. Just give me an antibiotic for a virus. Why would you want to take an antibiotic for a virus? I don't get it.
And this is the thing. We in primary care end up seeing the messes that occur. Because these cardiologists, for instance, will put people on 12 drugs or not feeling well, and they come back to me. They don't go to the cardiologist for that. They only go for the problems to me. And I suggest stopping the medicines, and they say, well, but they're saving my life. And I say, well, they're not, because you were living great before you started the medicines. And other than these little blips on these tests that we don't even understand, you're better off not. And often the cardiologists and the other specialists don't see the negative outcomes. I think that's part of the problem because they won't. They first of all, in my town, the cardiologists don't acknowledge they happen. I will tell you, Alan, for your case scenario, they would say that clot in the leg was purely coincidental. That
Right.
they have said things like that to me that are that shocking. But so they don't want to deal with negative outcomes. They're all gung ho and forward. So we'll
Right.
talk, and we'll talk more about it in a national level, maybe in a future podcast.
And the cardiac patient with congestive heart failure, for example, many of them are on at least 10 medications. And out of the 10 medications, like 7 of them lower your blood pressure. And like Andy said, they come in lightheaded, dizzy, they have a fall, and you do their blood pressure and it's 80 over 50. And the cardiologist says it's perfect. Like he's
Yeah,
gonna
that's
live
right.
forever because but the guy can't get out of bed or he goes to the bathroom at night, he gets lightheaded and dizzy, almost passes out. And one of these times he's going to fall and break his hip, and that will be the end of his life. But it doesn't go out to an adverse reaction from the cardiologist. The poor guy, had a bad heart and he fell on his way to the bathroom. He
Oh,
killed.
exactly. And numbers look good. And by the way, these 10 medicines they've put people on for congestive heart failure have never been studied in combination. And nor have they ever been studied in anyone older. And that's where the vast majority are given. I've talked to some really smart, theoretically, Hopkins cardiologists who say, well, look, the studies are good. I'm just going to give them all these medicines. But I'd say, but they haven't been studied together. How do we know? Well, because if one's good, then two's better. And it's like even my dad, who's terrible at math, had these statistical numbers given to him about his atrial fibrillation. And the cardiologist said, well, if you have a 1% of stroke this year, that means in 5 years you have a 5% risk of stroke. And my dad says, it doesn't work that way. It's 1% every year. That's how statistics work. I said, well, that's your well-trained cardiologist for you.
And now you have every cardiologist and every nephrologist prescribing, quote, the Jardians. You
Yes.
see the nice ad on TV. They're prescribing more Jardians than the primary care docs and the endocrinologists. It's a diabetes drug, and now it cures everything.
And my infectious disease colleagues say it's giving them a lot of business because everyone's getting sepsis and infections from the thing. But yeah, but that's coincidental also.
They don't tell you your genital organs could fall off,
They could, but that'd be coincidental. It would not be from that. Okay, so we will talk more about this, and we also on each of these, I'm going to throw in an article and maybe a book recommendation along the side after you read our book and our articles, of course, which are all on our website, returntohealing.com, and we have new videos going on there now. So you'll learn a lot, I think, from both those. So, Alan, we will talk next week.
So we don't just think it's a good book. We think it's a must read to save your life. It really talks about what's wrong and how to fix it. So we'll see you next week, everybody.
See you next week.
I think that was good.
Wait,
Good. Hear me?
wait.
Oh, we're still on.